This evening we're going to be focusing primarily on breast cancer screening. There are basically three screening modalities. One is mammography or mammograms. Number two is clinical breast examinations. And then the third is magnetic resonance imaging. So when an individual will have a screening mammogram, that means what?
They don't have any detectable symptoms.
You have no symptoms whatsoever, and that's why it's a screening study. So that you don't have any complaints of pain, tenderness, fullness, swelling. You have no complaints whatsoever. You're just going in to get this study as recommended by your doctor. Symptoms are things that are subjective, like pain, tenderness, as opposed to a sign, which is something that is objectively noted either by the patient or by the healthcare provider as they are examining the breast. A sign, which may also be a symptom in some cases, is finding a breast lump or breast mass, or even eliciting pain and or tenderness or a nipple discharge. So there are some things that can be viewed as both a sign and a symptom. The other test is a clinical breast examination. The woman is coming in to see her care provider. She has no complaints whatsoever, and that is just part of the overall physical examination that is being done by the provider at that time. And at that time, something may certainly be found. In the case of mammograms, once the screening study is done and something is found, then you move on to what's called the diagnostic images. And these are many more images looking at the specific area that has been noted by the radiologist, because they want to know if this is something that is real. Once they do the examination, if there is something that they notice, then they know what the next steps are. Usually, if the clinical breast examination is the initial test that is done, then that's going to follow with mammography, and depending upon what the mammogram shows, then ultrasound and beyond other studies that may very well can and will be done. The final screening test is magnetic resonance imaging. Before we were able to utilize the test for a breast cancer gene, we relied heavily on the family history. If there are at least two members of the family, usually premenopausal, who have had breast cancer, that is a risk factor for that individual who's in having an examination at that time. The other component of family history that's important is ovarian cancer. So if there are women in the family whom you know of, they've not had breast cancer but have had ovarian cancer, that puts you at risk of breast cancer. So therefore, part of the evaluation of that patient from a screening perspective there should be discussion about having an MRI performed. If a woman has a very strong family history of breast cancer and you've had your baseline mammogram and the baseline MRI, the patient should have an evaluation every 6 months. And with respect to mammography and MRI, those should be alternating studies. So that every 6 months, there's going to be an imaging study of some sort done in combination with a clinical breast examination. Mammography, clinical breast examination, and in the appropriate individuals, those who are at high risk of breast cancer, bilateral breast MRI. But those are the three basic screening tests that we have and should be used for early detection of breast cancer.
So if a parent has been tested for that and they do not have it, and let's say even both parents have been tested and they do not have that, does that mean it's guaranteed that their offspring do not have that?
It is not guaranteed. My comment is, in medicine, nothing is 100%. Okay? So the thing is, all of the mutations are not known yet. Okay? However, I think that if both parents are in fact negative, if they are tested, cancer can still develop, as you know. Because one of the risk factors in general, especially in women, is age.
Is there a specific zip code or area code that you can target or a relative cancer to?
Now, what you may be asking is how available are mammograms to those individuals who live in certain areas? That is access. There is the Wisconsin Well Women's program that is available to certain individuals economically, wherein they can, if they qualify, from their economics, they can have mammogram and cervical cancer screening. And those things are available here and now. So it's a matter of sometimes picking up the phone and just calling the state Department of Health and Human Services, and they can tell you locally where a center is if you want to get a mammogram and you can't afford to, otherwise you don't have insurance to do so.
For a woman with a strong history of breast cancer, family history, and who tests positive for the gene, what is your recommendation as far as preventive mastectomies go, or do you take a wait-and-see attitude?
What we do in a case like that is that we have the discussion about the options that are available to that particular individual. The options are surveillance, as you mentioned, and which is a wait-and-see approach. And with that surveillance, there should be a regular schedule of mammograms, clinical breast examinations, and MRI. Okay? The other approach is to take the drug tamoxifen, which we know works from the breast cancer prevention trial that was done, the P1 trial. And then the final approach, or other approach, is what we call risk-reducing surgery, which is a bilateral total mastectomy. So those are the discussions. That's the discussion we have with those individuals. I don't push them to either one. It is, we make sure that we take the time to explain each one and let them decide what they are most comfortable with. But stressing that you need to have some plan for follow-up in some way. That's how we approach it.